again, welcome to the Hirshberg Foundation for Pancreatic Cancer Research webinar, Pancreatic Cancer, Advances in Research and Patient Care. My name is Amy Reiss, and I am the Patient and Family Support Coordinator for the Hirshberg Foundation. Agi Hirshberg, our founder, is here too, and looks forward to saying hello at the end of the webinar. Please ask your questions either during or after the slide presentation by clicking on the chat button at the bottom of the screen and type and submit your question. We will open the discussion for all after the presentation. This webinar is being recorded and will be made available on our website, pancreatic.org. Now I'd like to introduce today's presenter, Dr. Mark Girgis, an assistant professor of surgery at the David Geffen School of Medicine at UCLA. His interests include robotic and minimally invasive approaches to surgical oncology, and more specifically on pancreatic diseases in his clinical practice as well as research endeavors. He received advanced training in robotic surgery and surgical oncology in his fellowship at the University of Pittsburgh. Dr. Girgis is committed to the improvement of cancer care through innovative technological advancements as well as groundbreaking research. Thank you, Dr. Girgis, for joining us. We appreciate you taking your time today to share this valuable information. Welcome.
Thank you very much. Thank you. Good to see everybody. I'm glad we're all staying safe, and hopefully we all are. I'm going to share my screen and just kind of get into it. Can everyone see this or?
Not yet.
Not yet. Okay, one moment. Sorry. Better now? Good.
Yes.
Okay, so yes, as Amy described, I'm an assistant professor of surgery here at UCLA, and I'm part of the group with Dr. Reber, Dr. Hines, Dr. Donahue, and Dr. King, who takes care of patients with pancreatic cancer. And, Agi and the Hirshberg Foundation asked me to try to relay some of the advances in research and patient care that have happened in 2019, kind of like a progress report where we are in, the struggle against this disease. So I will get right into it here. So I have no disclosures. Nobody's paying me for this. And my goal in this whole presentation is just to tell you that there's very much that there's hope here. You don't have to remember, all of the slides or even, pay close attention to the details or anything, but that as I'll hopefully outline in these choice topics that I've selected, that there's hope on the horizon. And I know we say this a lot, but I think we're reaching an inflection point here in pancreas cancer care and in the research, and I'm excited. I think this is a very exciting time. I'm very excited. So hopefully that's relayed in what I discuss with you here in the next 30 minutes to an hour. I'm going to start with the presentation is a progression. I'm going to start with some very basic science, laboratory-based research, what is kind of new and novel in the lab, in mice, hasn't been tested in humans, type stuff. And then I'm going to transition. The whole presentation goes from that area, the laboratory, to the the clinical trials, translational stuff that came from the laboratory, and then the last portion is the very clinical stuff that has been happening in the last year. So hopefully we'll see a progression through the whole presentation. So I'm going to get right into it. I'm going to present 5 or 6 articles that were new in 2019 about pancreas cancer and potential targets and options for therapy, things that we didn't know about before. This is the first one. This is out of Columbia University. There's this protein EIF4A. I think we all know that KRAS, I put here in this first slide, KRAS is mutated in most all of these cancers, all of our pancreas cancers, 95% of them or 92%, whatever. And this leads to an upregulation in this mTOR and MAP kinase pathway. This is well known. And these investigators found that this other protein, EIF4A, is also upregulated. This protein helps transcribe DNA, which is the building blocks for all cells, including cancer cells. It helps transcribe DNA into eventual proteins. So this specific protein is upregulated so that more DNA can be transcribed. So this group here, these are curves here on this side. This group here developed this CR31, and they gave it to these cells, and the cells that received it, this blue line, they died sooner than the other cells. Okay, that's encouraging. Over here is what cancer cells look like under the microscope, what a tumor would look like under the microscope. And when they gave this, again, this CR31, which targets that EIF4A, they see that the brown is gone. The brown is a marker of cells that are dividing or very active. When they give this, it's completely gone. Another way to represent this is when they give this CR31, the tumor growth is less. Here it's higher, here lower, much less. And this is also represented when they look at it under the microscope again. This cleaved caspase is a marker of tumor cells that are dying. You can see that there isn't as much brown here as there is here. This is better brown, which is that tumor cells are dying. Again, supporting that this molecule is targeting that EIF4A, that EIF4A is important for pancreas cancer cells, and that molecule is targeting it. So they put these tumors into mice. I'm going to point to the tumors in these are PET scans that they did for mice. They did PET scans for mice with these like tiny machines. And I'm going to point to this one because this is a really good image. This is the tumor right here. And you can see how bright it is. That's without any treatment of anything. It's very bright, very active on the PET scan. You can see the tumor very well. When they give the medication, now you can see it's much less bright. And similarly, the mice who had these tumors, when they were given the medication, this is the blue line, that's the medication here, they died later. So yes, the tumor continues to grow, but at least it delays it a certain period of time. Again, this is just laboratory data based off of mice work and just supports the interrogation or investigation of this protein. So I'm going to summarize very quickly. This protein helps pancreas cancer cells grow. Secondarily, it can also be targeted with that molecule that they developed to prevent growth of pancreas cancer cells. Those are the takeaway points. Another one, immunotherapy is very popular in many cancers, and pancreas cancer is no different. For patients who have sought out immunotherapy, we've learned that pancreas cancer, for some reason, is not as sensitive to immunotherapy as melanoma or lung cancer or these other types of cancers. This particular article looked at why that was the case. This is I know this is very hard, but I'll try to make it very simple. The reason why immunotherapy currently doesn't work for pancreas cancer is because the T cells, which are the cells that are needed for the immune system to work, they get tired. In a very simplistic way, they get tired. They see all these bad cells that they want to eat and kill, and it overwhelms them and they get tired. When we give the immunotherapy drug, usually we give one immunotherapy drug at a time. It doesn't overcome this tiredness of the cell. In this study, these physicians in mice, what they did was they gave not one, but two in this graphic over here, this portion over here. They gave two immunotherapy agents. Here they give one, here they give two. They're representing here this green being active. So now the T cell is active because they gave two. Whereas here, because they only gave one, it's, you know, red, stopped. It's not as active. It's a little bit more tired. This translates into response for most patients. Usually there's eradication of the tumor. Sometimes there are tumor cells that escape still, but the idea is that this combination of two immunotherapy drugs is helping reactivate the immune system, whereas only one immunotherapy drug doesn't reactivate it well enough. Again, they did the study in mice. This is a survival curve. These are mice that were not treated. They die early. These are mice, this blue and red are mice that were treated with one or the other immunotherapy. They survive a while longer, but look here, when they give both of them at the same time, the screen line, they survive even longer. So the takeaway point here is, number one, T cells get tired, and because they get tired, that prevents efficacy of immunotherapy currently. And because this T cell tiredness or exhaustion, they give the dual immunotherapy, which can overcome that tiredness. So that's hopefully where things are going to move to in the next couple of years. We may latch on to this and start doing this for our patients. But again, I'm going to reiterate this every single time. This has only been done in mice so far. This was a very interesting study. I really enjoyed reading it. This is new, and I know this has been talked about a lot, but the influence of the tumor microbiome. Microbiome is the tumor, the bacteria in and around the tumor tissues. So these people, they removed, I think, 65 cancers, and they kept them, and they looked at all the bacteria in these cancers. And they very simply noticed two things. First, the bacteria in these patients, the long-term survivors, the people who lived longer after they got their surgery, those people had different bacteria, period. Okay. They also investigated the tissues to see what the T cells, remember I was referring to the T cells that eat the cancer cells in the last, from the last article over there. They looked at these T cells in the microenvironment of the cancer, in and around the cancer, and they noticed that they were much more active. One of the premises here is that activation of the immune system identifies these bad cancer cells and either, you know, eats them, kills them, or at least keeps them quiescent from growing, you know, out of control. The idea here is because the bacteria is for some reason different in these people, the immune system is activated more in these people, and thus they live longer. Very interesting study. I'm sure this is going to continue, and people are going to be looking at this for a long time. Okay, so this paper here, I want to draw attention to this first name, Wantong Yao. I don't know if Agi remembers this person, but she was a recipient of a Hirshberg Seed Grant a number of years ago, and now she's publishing major articles here in this journal Nature. This is one of the premier journals in the scientific community, if not the premier, actually. And she showed us something new also. This idea of, I'm going to say this word slowly, macropinocytosis. This is a way for cancer cells to engulf the nutrients that circulate right around it. It's a way for those cancer cells to engulf those nutrients and then use them so that they can grow and grow faster than other cells. What Dr. Yao noticed was that cancer cells do this more when they have this protein SDC1, which is syndecan-1, SDC1 on the cell surface. So what they did was these red dots is macropinocytosis happening. This is normal. When they block with a drug, when they block the syndecan-1, you see that the red dots go away. This is one way of blocking it, this is another way of blocking it. The red dots go completely away. So this indicates that this protein, syndecan-1, is really important for the cells to get nutrients, that macropinocytosis, for that to occur. And of course, we know that without the nutrients, then the cells, can starve and die. And they showed this in this graph here, which is, I know there are a lot of like small numbers here and all that stuff. Don't pay attention to any of this stuff if you can. I want to show you, just look at these lines here. These are mice who have normal syndecan-1 in their genome and has been upregulated on the cancer cells. These two groups of mice are mice that have been manipulated. The mice themselves have been manipulated to not be able to express syndecan-1, and because they can't express that syndecan-1, they live longer with cancer. Again, they still die eventually, but they live significantly longer. Okay, so takeaway points from this. Syndecan-1 is upregulated on pancreas cancer cells, and blocking syndecan-1 results in delayed tumor growth. Again, done in mice only. This is not, none of this is yet ready for prime time. It's still in preclinical stages. Now we're getting to things that are closer to ready to be used for prime time. This is a this is a paper out of Nature again. Again, mutant KRAS, which is essentially all of us with pancreas cancer. Increase of this protein ERK, it's a kinase, and that increases this process called autophagy. Autophagy is a way for cancer cells to recycle and reuse nutrients. Again, macropinocytosis is one way, autophagy is another way of cells engulfing other cells and using their machinery to grow. So the idea is that autophagy is bad in cancer, because if we can block autophagy, then we can limit the ability for cancer cells to get these nutrients from other cells. And that's what they did here. They gave an inhibitor to that protein ERK, and they gave this CQ, which is chloroquine, to tumors, and the growth of those tumors significantly decreased. The growth of those tumors significantly decreased. When they gave these same medications to mice, you can see that the tumor, this red line is those medications, the tumor volume, so they measure the volume. You can see from the very first day all the way to 22 days, it's essentially stable. There's no additional growth. So if you are able to block the ERK protein, and you're able to block autophagy with this HCQ, hydroxychloroquine, if you're able to block it, then the tumors don't grow. And this is just another graphical way of presenting that data. This is the combination over here. The tumors are very low weight, corresponding to the tumors not growing in the mice here. So the takeaway from this study is that these combination therapies of ERK and autophagy therapies can slow the growth of these tumors. So I want you to note that the tumor didn't go away, it stayed the same. So it slows the growth. So don't think that all these studies are being done elsewhere and not at UCLA. They're happening at UCLA also. So I will plug UCLA a little bit in this. One of my friends and collaborators, Dr. Donahue, is the lead author on this paper. This journal is a very highly regarded journal in the scientific community. And he also has been interested in autophagy, as well as the ability of the cells to use DNA to replicate. And what they did was they used that chloroquine, which inhibits autophagy again, and another molecule to inhibit replication. And these two molecules together that's this bottom line here, slows the growth of these tumors. And this is a visual representation. You can see these big tumors here, and with the two medications, the tumors are much smaller, this tumor versus this tumor. So a potential option there. And they did the same thing in mice. Here you can see that when these two medications are given, this dashed line here, which is this line up here at the very top, the tumor volume or the survival of the tumors is high, the survival of the mice with the tumors is highest with those two medications. So here, the takeaway points are autophagy and replication interact closely with one another in pancreas cancer, and inhibiting autophagy and replication can effectively slow cancer cell growth. All right, I'm going to transition here. That's all very, preclinical, and I'm going to transition a little bit into the ongoing scientific things that are happening and being put into patients. As we know, KRAS is mutated very frequently in pancreas cancer patients with these other genes mutated at varying degrees in pancreas cancer patients. Specifically, if you can pay attention to this upper left one here, the area of the KRAS gene that is mutated is this G12 site, and it's most of the time mutated to a D. These are amino acids. This amino acid is mutated to this amino acid 51% of the time. 30% of the time, this amino acid is mutated to this amino acid. This is all the same KRAS. It's just the mutation at that point can vary. This specific one, G12C, this KRAS is a thing, as we've discussed, as I've said over and over, is mutated in 95% of cancer patients. So why can't we just develop a drug to KRAS? For the last 30 years, this KRAS, you've probably heard it, is called untargetable or undruggable because nobody can figure out how to get a drug to it that effectively binds to it. And there are all these different mutations. Well, I am very much here to tell you today that KRAS is not untargetable anymore. A company in Southern California, Amgen, developed a drug to KRAS, to a specific KRAS mutation, the G12C mutation. And as I go back, that's actually only 2% of pancreas cancer patients, but it's still promising that KRAS mutant can be targeted and can have a drug developed for it. With the drug, these mice with these tumors had an actual decrease. It wasn't just stable. This red line shows with 100 milligrams, this tumor decreased in size. And this is by itself. This is not with chemotherapy or with immunotherapy. This is just the inhibitor by itself. And they did this, they put that inhibitor into patients, not pancreas cancer patients, but they put it into lung cancer patients. The reason why they put it into lung cancer patients is because 30% of lung cancer patients have this KRAS specific G12C mutation. And here are some examples of the patients improving. This nodule goes to here, this to here. These are patients with metastatic lung cancer. These nodules get smaller. You can see the size, this one to this one, and even to this one. So very promising work here. It's in the early stages of phase 1 and phase 2 trials, mostly for lung cancer, but it will be extended, I'm sure, to pancreas cancer. And the idea here is that this KRAS mutation is now targetable, and this inhibitor for lung cancer patients has great promise. And I should have put a third point here, which is if they can figure it out for that specific mutation in KRAS, you know, it's not far off that they'll figure it out for the other mutations in KRAS for the pancreas cancer patients as a whole. So this is going to happen, I think. You know, it may take 5 or 10 years, but this is going to happen. Okay, so I put a picture up for myself because in 2016, I was honored to be a Hirshberg Seed Grant Award recipient, and for that award, it was called targeting, FAP on cancer-associated fibroblasts for pancreas cancer, and that work has led to this development, which is that there's this new PET, usually PET imaging is done with glucose, or radioactive glucose, but recently this new protein molecule was developed for PET imaging for pancreas cancer patients. And this also is work done here at UCLA in our nuclear medicine division. But this is a patient who has pancreas cancer, and you can see all of it lighting up here on the PET scan. The idea here is that this molecule will be better than glucose for finding the tumor deposits in patients that have metastatic pancreas cancer. So this FAP PET is investigational. It's on clinical trial here at UCLA, and we have been enrolling patients, and it may improve diagnostic accuracy of metastatic pancreas cancer. I've already, we've already, applied this to 20 or 25 patients, and it's still ongoing. So this is exciting stuff here. Again, work supported through the Hirshberg Foundation. Okay, now we're transitioning from the investigational things. We went from preclinical to investigational to the new clinical, standard of care and the trials that have been completed. Now, this is a study in the New England Journal of Medicine, which is highly regarded as the top clinical journal in the country, and maybe even of the world, probably of the world, actually. This medication, olaparib, for germline BRCA mutated metastatic pancreas cancer patients. BRCA is mutated in about 7%, 5 to 7% of patients with pancreas cancer. And these people selected out those patients who had that BRCA mutated and gave this medication. This medication blocks a component of cells being able to repair DNA. And for cancer cells, we don't want to be able to repair DNA. We want their DNA to degrade so that the cells die. And this medication helps make that happen. They gave this medication, which is very well tolerated to patients, and patients had a greater time to progression of disease. So that means at 6 months, patients who got nothing, at 6 months, patients who got the medication, 50% of patients who got the medication did not have progression of disease. They had stable disease, whereas the other group, only 20% of them had stable disease and 80% of them did not. 80% of them had progressed. So this medication helps halt the progression of cancer, of metastatic pancreas cancer, which is what I'm saying here. but it's only used for those patients with this BRCA mutation. The reason why is because this BRCA mutation makes them sensitive to this medication specifically. Another clinical trial that is ongoing is for those patients not with metastatic pancreas cancer, but with those patients with locally advanced. Locally advanced, we call patients whenever their tumor is encircling the veins or arteries around the pancreas, which makes it very difficult for surgeons such as myself to be able to remove them. However, at Massachusetts General Hospital, they developed this trial, which is called total neoadjuvant therapy with FOLFIRINOX chemotherapy in combination with losartan. Losartan is a antihypertensive medication. Who knew that we could use it for pancreas cancer? It's an antihypertensive medication. Very interesting. But they used the chemotherapy with the losartan, in which case of the 49 patients, 45 were able to complete that. Then they gave a little bit of radiation with chemotherapy. 42% of patients, or 42 out of the 49 were able to complete that. And then out of that, they had such a good response that 34 of these 42 were able to get surgery. And these are patients who often are unable to get surgery at all. Of those 34 patients who were able to actually get surgery, they had an average survival of 33 months, so almost 3 years of survival in a disease, locally advanced pancreas cancer, that typically has, 16 to 20 month survival, and most patients aren't able to get surgery. This regimen is able to downgrade patients so that they are able to get surgery and live longer. So the takeaway points here are aggressive chemotherapy and radiation can convert unresectable cancer to resectable cancer. And when resection can be done, the average survival is almost 3 years. Okay, this is the landmark trial of the last year. This is actually published in December 18th, 2018. But I'm including it in 2019 just because it was so important and so landmark. And I just want to make sure that we all know about it. Specifically that this multiple chemotherapy regimen of FOLFIRINOX, it's 4 medications, versus the older stuff, the gemcitabine, for chemotherapy for patients after they've had surgery. So these are patients who had surgery. And as we all know, chemotherapy is a very important part of our treatment for pancreas cancer. So it's almost always necessary for our patients. So whether we give one versus the other, we'd like to know which is the most effective. In this case, we discover that this 4 chemotherapy regimen, modified FOLFIRINOX, is better. And in fact, it's really good. It's really good. The average survival of those patients was 4.5 years, which is way higher than what we've seen in the last, with gemcitabine. With gemcitabine, the average survival is 2.5 to 3 years. With FOLFIRINOX, it's a whole 1.5 years more. It's the longest we've seen in pancreas cancer in recent decades. Some people do have difficulty with this chemotherapy because that's 4 drugs versus 1 drug. But even though it's a little bit more difficult, the benefit is clear. And finally, we've talked about a lot of different things, PET scans, drugs, medications, but on the surgical front, for those patients who are able to undergo surgery, there are options and there's ongoing research. This is one of the more important publications in the last year on surgery for pancreas cancer. You can notice maybe that I was the one, I'll plug myself again, who performed this study. Excuse me, sorry. I'm sorry that the data is a little bit blurry, but all these bolded numbers here, are are the benefits of robotic surgery versus the standard open approach. All these bolded numbers. So we get more lymph nodes. The OR time is a little bit less, although it's probably not that different. The estimated blood loss is definitely less, a lot less. The number of transfusions is a lot less. The number of infections in the skin is a lot less. The number of overall complications is about the same, but a little bit less. The length of stay is not, the length of stay is less, 9 days versus 7 days, so 2 days less. When you get the surgery with the robot. This is minimally invasive surgery, and as Amy was suggesting earlier, this is one of my interests. We were actually surprised in the end to find that these outcomes, these benefits of the robot led to a small increase in survival for pancreas patients. The patients who had the traditional open surgery, they survived about 2 years after surgery. The patients who had the minimally invasive surgery, they survived about 2.5 years. So, I mean, it's not a huge difference, 6 months, but there was a small difference. We attributed this difference to the improvement in perioperative outcomes. I think it's pretty obvious that if your surgery can be done minimally invasive, then the perioperative outcomes, the outcomes around the time of the surgery, tend to be better. And this improvement can be linked to improved survival, but it's important to note here that using the robot for pancreas cancer is not inferior to open. It is at least as good as open and maybe better. The reason why I stress that is because there was recently at the end of 2018 or early 2019, the FDA kind of put a warning on robotic surgery for cancer. It was all over the news, highly publicized. And that was one of the reasons why I decided to undertake this project, was to show that at least in experienced hands, which myself and the other people on that paper are, it can be done very safely with improvement of outcomes and maybe even improved survival. So encouraging point. So that's going to conclude what I have to say for today. I hope I didn't bore anybody too much. Thank you for allowing me to address everybody, and I'm happy to take any questions that anyone may have. Thank you so much.
Do we just ask a question on the line?
Sure.
Yeah, thanks for that. It's very useful. The one thing that came to light was the study with Losartan and the excellent results there. There's also some decent results with paracalcidol and hydroxychloroquine. Given they're all off-label, and it would seem fairly obvious to combine them all in a clinical trial, is there any plans to pull the kind of off-label drugs that are already regulatory approved into a single trial?
Yeah, I mean, that's actually a new paradigm of that's a new paradigm of getting things to patients, which is drugs that are already approved, that can be given off-label, and it's not that hard to give off-label. These, hydroxychloroquine. I mean, it's even being talked about given off-label for coronavirus these days, right? I mean, it's all over the news, so that's a new paradigm in trying to treat these patients. But to your point, no, they haven't been specifically combined, and as far as I know, there's no plan to combine the hydroxychloroquine as well as the losartan or anything else. The reason being is because those specific combinations of medications haven't really been investigated in the preclinical, meaning the mouse models of pancreas cancer. And until that happens, we usually don't combine medications until there's at least some idea that it's going to be safe for people. It's hard to just combine this medication, medication, and this medication, which can potentially have serious side effects. So we like to know about those toxicities before giving them to patients.
Okay. Okay.
There are chat questions. Can we pull
Yeah,
those up?
I can go to I have a couple questions. Somebody asked, dual immunotherapy only increased lifespan by 10 days. Is that significant? For mice, it is actually very significant. It's all, that study of immunotherapy is not in patients. It's only done in mice. And if you were to just give no immunotherapy, those mice would die in, I forget what the study showed, but they die within, less than 20 days or something like that, very, very fast. If you give the one medication, it's, 35 days. If you give the two medications, it's like 42 days or something like that. So in mice lifetime, if you will, it is actually very significant. But again, this needs to be retested in patients, because what happens in mice and happens in those tumor models, to be very honest, infrequently translates into what happens for patients. We're often excited by what we see in the lab, and unfortunately, patients behave differently.
Dr. Girgis, there were also some emailed questions that I would like to read off. The first one is, if the pancreatic cancer has metastasized to the liver, what are the options?
So the first option for patients who have cancer that has metastasized to the liver, the first and still the best and the most tested is chemotherapy. And I know that, makes us cringe a little bit, because we know chemotherapy can be toxic, but unfortunately, it is the most effective, it's the most well tested, and gives us the best chance. As I discussed, there are other options if you have specific mutations like a BRCA mutation or something like that. We often will do, in patients with metastatic pancreas cancer, we'll often do genetic testing of the tumor or the patients to know if there are other mutations that we have drugs for that can be helpful and beneficial. But the mainstay is chemotherapy, with these other things like immunotherapy or T-cell therapy or small molecule targeting agents for these mutations as, second, third, fourth line options after the first primary option of chemotherapy.
Okay. Sorry, there's two more questions that are sort of related to this, and then there's also another question in the chat that we'll get to. But the second sort of follow-up to that first question was, how long can someone be on FOLFIRINOX?
Yeah, that's a really great question. FOLFIRINOX, it can be toxic, but I'll tell you that people tolerate it very differently. So I've had patients, I don't want to say breeze through it, because it does cause some side effects for a number of people, but I've had a lot of patients do very well with it, tolerate it, continue working while on it. And I've had other patients not do well with it at all. As it relates to your question, I've had patients on it for 2 years. And variations of it. Sometimes it's FOLFIRINOX for a year, and then one of the medications is dropped, or two of the medications are dropped because of side effects. But it can be a long time. It's helpful, though, to get breaks throughout, because the toxicity can add up. But everyone responds on, the small difficulty in all this is everyone responds with toxicity a little bit different. So it's hard to know if, person A is going to do well with it versus person B versus person C. It's unfortunately got to try it. And you may be one of those people that responds very well to it and doesn't have many side effects. You just kind of have to try sometimes. We can't identify those people that will do well with it, we can't yet identify those people who will do well with it or will not do well with it.
Okay. And then the final sort of follow-up question to that, it sounds like they were on FOLFIRINOX and it shrunk the tumor, but not enough to be Whipple eligible. So the question is, what is the next step if the Whipple operation is not possible?
Yeah, that's a great question too. So there are a few options still. In these patients, we often recommend, as I was saying, for the metastatic patients, we recommend genetic testing so that we can find any mutation that can be targetable, or we have a known drug for it, which can be helpful. We often recommend radiation to that area, which can also be very focused and very targeted radiation, which can help not only kill the tumor cells, but prevent their growth for a while. And last, immunotherapy is another option if your tumor has the appropriate mutations in it to be beneficial for immunotherapy. And then finally, there are some more invasive options called irreversible electroporation, which is a type of energy that is applied to the tumor that helps kill the tumor. None of these things are curative. However, they can absolutely give you many months longer in life.
Wonderful. Thank you for addressing those questions. We have a question from Lynn in the chat about Climavax, developed in Cuba for lung cancer, but they believe it is being tested in the US for GI cancer.
I can tell you that I don't know what Climavax is, but I'll look it up.
Thank you for your honesty with that.
So I see it now.
Okay.
So Climavax is a type of vaccine used for patients that have it's a vaccine against something called epidermal growth factor, which is a growth factor that binds to receptors on cancer cells and helps, or all cells really, and helps stimulate their growth. It's just that cancer cells have these mutated epidermal growth factor receptors, and the epidermal growth factor receptor is always active regardless of whether there's a molecule to stimulate it. The vaccine is used for lung cancer because lung cancer has often upregulation of the epidermal growth factor receptor and mutated receptor, and that's why it's used for that. Pancreas cancer does also, but not nearly as frequently and not nearly to the extent that lung cancer does. So I think it's reasonable to try for certain cancers, but I think it's going to be based off of whether the tumor itself has the appropriate profile for it. But I don't know if it's actually being tried or not. I don't know.
Okay, thank you. We have one other question about what is your opinion about CT scan versus PET scan post-surgery / chemo for follow-ups?
That's a great question. You know, this has been preliminarily investigated. It was actually a number of years ago, but PET scanning has gotten better. So maybe it needs to be evaluated again. But right now, the guidelines are to do CT scans. The quality of CT scans is very good, and we believe that PET scans don't specifically add any more than a good CAT scan does. That being said, these novel PET scans that myself and my colleagues are working on may actually be better, but that will need to be investigated. So right now, CT scan is my opinion. It's also what we do here at UCLA. But I think there is an emerging role for PET scan that needs to be delineated.
Wonderful. I'm going to read off Kelly's question. It's a little lengthy. She says, they say, since diet is important in the fight to recover from pancreatic cancer, I'm wondering if consuming products with caramel color, which is linked to pancreatic cancer, is akin to smoking while on chemo for lung cancer. My dad, who has had a few rounds of chemo and will have the Whipple procedure next week, wants to consume these products still because he doesn't believe in the link between caramel color and pancreatic cancer, though the NIH has published articles.
One moment. Let me just, yeah, so I see what she's referring to. Thank you for that. Thank you for that question. It's very difficult, if I may say, because it isn't, I can promise you that it's not just caramel color that's contributing to his cancer. These things are always multifactorial, and it's hard to consider one aspect in a vacuum. I mean, caramel color is probably not very healthy for any of us, really. But on the flip side of this is, you know, all of us, especially during challenging times, need our emotional and mental fortitude or stability. And sometimes, you know, I wouldn't say smoking specifically, but sometimes something like caramel color, or, you know, that extra candy that one night or whatever it is, can on a personal level be beneficial to that person. So I can't specifically say, you know, I really suggest your dad should stop the caramel color. I wouldn't say that, because I don't think that doing that specifically is going to make a huge difference. But yeah, I don't know what more to say than that. Diet is important. I will support you in saying that, and eating a healthy diet and a nutritious diet, and even consideration for probiotics, I think, is a good idea. But I couldn't honestly, with perfect, with you know, perfect insight, say that caramel color should be avoided.
Okay, thank you. I know that it's often hard to find the sort of correct balance between the science and how it translates into the person. We have one more question from Laurel. My mom is on a 3-week time frame for FOLFIRINOX with the wonderful Dr. Zev Weinberg, also of UCLA. We know protocol is a 2-week time frame between infusions, but that was hard on her. Thoughts regarding efficacy?
Yeah, you know, I think that, so the real answer is, just because the 3-week time frame wasn't tested doesn't mean it's not as good. That's essentially the answer. I think it's perfectly appropriate. I think that just getting the chemotherapy, even though it's slightly delayed, every cycle is slightly delayed, is more beneficial than, you know, just giving up on it completely or doing something else, specifically that chemotherapy. You know, I obviously work with Dr. Weinberg very closely, and if he wanted to give you smart water and said that would treat pancreas cancer, I would support him in that too. But that, I'm joking. But I think it's very reasonable, and I don't think it's going to make a significant difference one way or the other, that 1 week difference.
And there was one other question from Melissa. How do you determine dosing for the chemotherapy drugs?
Yeah, that's a great, it's based on weight, actually. It's based on weight. All of the drugs are based on weight, and that's part of clinical trials and why we do them. It's to determine which dosing based on weight has the right amount of toxicity for the best benefits. You know, minimizing toxicity but maximizing benefits. So it's based off of weight.
Okay. Are we ready for any more questions?
I have another, can I ask one more regarding the
Of
dosing?
course.
I understand that you determine it by weight, but how do you determine whether the course is going to be, let's say, once a week for several months versus, 2 times a week for 2 months? Do you see what I'm saying? Like
Yeah,
lower
yeah.
dosage, spreading it out versus higher dosage in a shorter amount of time.
Yeah. Also based off of the clinical trials. So like this one person asked about the 3-week time frame for the FOLFIRINOX instead of the 2-week time frame, kind of like that. Is that kind of what you're alluding to, Melissa?
Yeah, someone else, another physician utilizes a protocol where you go in weekly for ever, essentially at low doses.
Yeah, no, I totally understand. I think I know the physician you're talking about.
Right.
Pardon?
Yes, I'm sure you do.
Yeah. And he has tons of experience, and I support him also. But we use the best available data that we have. That's how we drive these things. So,
But I think it's a good. Oh,
sorry. I was saying that the trial was done in a certain way. Does that necessarily mean that the other way is not correct or not well done? No, it doesn't mean that. But at the same time, it hasn't been tested, so there's a little bit of doubt. Does that make sense? We know that, and that's why the question arises. That's why the question arose from this person about the 3-week time frame. There's just that little bit of doubt because the trial was done in a certain specific way, and we try to do that for our patients. But I don't know if the 3-week time frame, I don't specifically know. I don't think it matters, but I don't specifically know because it wasn't tried. So the fact that that physician is using, their own cocktail and their own timeline and so forth, that may actually work very well.
Okay.
We try to use data and evidence to guide everything we do. So when somebody says there's no data to support that, that's exactly what it means. There isn't any data to support it. That doesn't mean it's wrong. That doesn't mean it's right. It means we really don't know. What we do know is this data, because it's already out there. Does that make sense?
Yes, thank you.
So I'm sorry if I'm not.
No, I
don't want to be vague or skirt the answer, but that's how it is, really.
I gotcha. Thank you.
Yeah.
I'm just going to follow up on that if it's okay. Have we got time for another follow-up?
Of course, I have all the time in the
Yeah.
world.
So on that, it's a common theme, the discussion on low dose chemo. There's lots of evidence that people who can afford it are getting. There's lots of evidence that there are a lot of long-term responders to low-dose chemo. There's lots. I think the question, and it's a hard question to put to you because you're one individual in an organization, but is the medical industry and the FDA set up to be able to test it, to actually put it through the process of seeing its effectiveness in a trial?
No, I think absolutely. And I think that's the idea. I think that's the idea. What I'm trying to support is that these novel treatment options, 3 weeks or low dose chronically for a year or whatever, I think they need to be tested. And it's not a function of necessarily the government. It's actually a function of us as a physician, as a community, to support and enroll patients onto more clinical trials to gather more information. So I support you 100%. You talk about there's evidence for this, there's evidence for that, and there is. There's a strength of evidence for one thing versus another thing. And the strongest evidence that we can develop is these clinical trials. So what we need more of are physician communities coming together, running these clinical trials so that we can gather the information for what is best for our patients.
And then how would, let's say, actually in the process of setting up a foundation itself, but based off taking evidence from people who've paid for their own treatment protocols, using off labels, using integrative oncologists who use these mechanisms, and we're collecting that data to sort of assess how they're doing, and it's the gut is telling us that they definitely are effective in getting long-term responses. So how would we funnel that into the industry to say, look, you do need to test this?
Yeah, so I mean, so how would you funnel that into the industry? The physicians who believe it need to, so there are, protocols like review boards, you need to like register clinical trials on a government website, and these types of things. All of these types of things need to be completed so that a clinical trial can actually be run to really test if, one type of therapy is better than the other type of therapy. So there's a lot of red tape, for lack of a better way of saying it, that needs to be completed for these projects to be done. And then a physician community, like I was saying, who's willing to support it and actually run the clinical trial. The physician community needs to run it.
But why has there been a resistance though? There's it's been going, the discussion's been going on a while, and they know the mechanisms to why it's working. Again, not for everyone. It's just that we're not seeing it actually being moved into the clinical trial world.
Yeah, it could be multifactorial. Change is difficult for everybody, and especially if that change or that idea, I don't want to say it's radical, but not mainline. We're all we all like to be mainline people and just kind of go with the flow of things. And it takes real initiative from those non-mainline people to be able to do a project like this, to convince people that their ways are beneficial and correct, and get them on board to try to do these projects. It's hard. There's nothing more than, it's hard. Sometimes what can be helpful is if there's good preclinical data, these mouse models, this mouse data that I was showing you, these can be helpful in supporting their cause. But ultimately, you have to have a group of people that are willing to do that therapy to try to move it forward.
I'm going to pipe in right now because we've passed our hour session, and Dr. Girgis has been so graceful to give us his time and his busy schedule. And I almost feel like I should get college credit for listening through. It was absolutely wonderful, and I really want to thank you for mentioning Dr. Ya and all the other seed grants that UCLA has given as well. That the work we're doing, the work we're funding is making a difference, and that's Absolutely. Very important to all Absolutely. Of us. So bless you for just really giving us a wonderful education.
Thank you.
And a couple of weeks from now, dear patients, hello Barbara. It's so nice when I see your photos. It makes it more of an intimate meeting. You know that we're keeping up with information for everybody. The next one is May 29th, Dr. Wendy Conlon, and you know that if we have a session 6 months later, there's new information. So I thank you all, and see you in a couple of weeks.
Thank you, everyone. Thank you. I hope I didn't bore anybody too much, and I appreciate the opportunity, and bless everybody for their interest in this, and keep it up.
Thank you.
Thank you. Bye.
Thank you, Dr. Girgis. You've gotten a lot of thank yous, starting with our dear friend Tom Rozak, and Karen and Kelly and Laurel. Many thank yous for a great presentation from all of us.
Absolutely. So grateful, and thank you. Take care.
Bye, everybody.
Bye.